the intensive care nutrition program and the pediatric critical care fellowship. This is a very important webinar for our Walid Institute of Critical Care and Emergency Medicine. And we have two great speakers today, Dr. Fatima Al-Haddad and Dr. Ali Ali. And I'll let Dr. Khaled Swifi to introduce our rest of speakers, including Dr. Crystal, our moderators, in a couple minutes. But I just want to give you some heads up about our Walid Institute of Critical Care and Emergency Medicine fellowships. We are running 6 fellowships now between intensive care, nutrition, pediatric critical care, point of care ultrasound, cardiac critical care, neurocritical care, and respiratory critical care. We have more than 600 fellows from 42 countries. So we are very proud. And our intensive care nutrition fellowship and our pediatric critical care fellowship are structured as 3 modules each. And each module has 16 weeks of intensive education. It's not monologues, but it's dialogue, and we are happy to let our fellows be engaged in our educational materials. Again, we know that our learning retention rate and our retention pyramid is very limited when it comes to lecturing or reading. So we try to have a discussion, have a dialogue, and bi-directional education, involve our fellows in demonstration and the practice doing rather than just to give them one-way education. So there is a lot of questions and answers, evaluation and assessment, critical thinking, and brainstorming, and we gather expertise from all over the world to give this high-quality scientific materials. So these programs are wholly online, and it's not based only on webinars or seminars, but there is a lot of workshops and video conferencing and case-based discussion. All of our fellows need to submit their tasks and assignments every week before the end of the week, but they have the freedom throughout the whole fellowship to navigate through the scientific contents and educational materials. So all of our fellows' activities are monitored through a smart platform, and all the assignments are based on weekly basis. And upon completion of the fellowship, all of our successful fellows should be expert in the field and should graduate to a trainer mentor level. And also they are going to receive accreditation with a graduation certificate from the American Association of Continuing Medical Education. So today, this is our agenda. Our first speaker will be Dr. Ali Ali from University of Southwestern Texas, Dallas, Texas. He is a critical care fellow. He's very smart, very good educator and instructor. Then Dr. Fatima Al-Haddad will give us some highlights and background how to prescribe the nutrition and the enteral nutrition, mainly in sick children. Dr. Crystal from Lebanon is going to lead the discussion. And my dear Professor, Dr. Khaled Swifi, is going to lead the whole webinar and to give the take-home messages. Just some housekeeping stuff before I will let Dr. Khaled Swifi to lead the fellowship webinar. First of all, you can activate the transcription if you want. There is 50 language that when you activate the show caption option in the left part of your screen in the Zoom, you can see the transcription of all the spoken languages in your at your earliest convenience. You can see it on the screen. So please try to activate the show caption, and you can choose your own language. Then the recorded webinar should be ready by tomorrow. So all of you should receive the link for the YouTube link for the recorded webinar by tomorrow. And you should also receive the attendance certificates by next week. With that, I'm just going to highlight that all of our activities and educational events it has no value except we change our clinical practice and we improve our patient outcome, because knowledge itself has no value unless we put it in practice, and the great aim of education is not the knowledge, but the action. With that, I'm going to let Dr. Khaled Sawifi, who is a dear friend of myself, and he's the Vice President of the World Institute and Critical Care and Emergency Medicine, and he's also the Intensive Care Nutrition Program Director, and actually is also trying to create another weight management fellowship for the next year. So he's not only expertise in critical care, but also expert in the field of nutrition. So I'm going to let him to lead this webinar, and welcome, Dr. Khaled. Please unmute yourself, Dr. Khaled.
Thank you, Dr. Am, for introducing the webinar, and thanks for the speakers, Crystal, Fatma, Ali. Thanks for the attendees. I can see now 292, and probably will be more with time. Without further delay, let us to hear to Dr. Ali, and we'll start later on the discussion. I'm sure the lecture will be of value for all of you. And as Dr. Amr mentioned, let us to be a kind of dialogue rather than monologue. So we'll have a discussion and question and answer, and all of us will share together. Again, without further delay, let Dr. Ali to start. Start, Dr. Ali, please.
Thank you so much. Let me just share my screen for a second. Are you all able to see the screen right now?
Yes, can do that.
Perfect. Okay. Thank you so much for the introduction. As everyone says, I'm Ali. I'm one of the senior fellows here at UT Southwestern in Dallas, and one of the board members from Wickham, but in the Critical Care Fellowship in the ICU. Today, I'll be predominantly talking in case scenario concepts in nutrition and pediatric acute critical illness. And I want you to grasp this is a 10-minute lecture, so I'm predominantly focusing on general concepts rather than a deep dive into actual case details. And if anything you need to take out of this lecture is enteric feeds, feed the gut, feed the gut, feed the gut as much as you can, if appropriately indicated. So the first case I wanted to highlight is a septic shock patients. If you get a 7-year-old child with septic shock, it's already diagnosed, the patient is intubated, the patient is hemodynamically unstable, and the child is always at risk of malnutrition. But there's a risk of non-functioning gut due to the ileus, and the multidisciplinary team are discussing what's the optimal nutrition management strategies that we can tackle. There's always a question is how can we feed? What's the preferred route to feed patients when they have functional gastrointestinal tract in shock state in the ICU? And the answer is always going to be enteric feeds. If you're able to feed them through the enterical nutrition, it's always preferred over the parenteral nutrition. And this is the ASPEN and the SSEM guidelines. We know that early enteric nutrition in these patients depends on once their hemodynamic and resuscitations are stable, they have improved gut integrity and reduces the risk of infection. But then the question is, when should we use parenteral nutrition if we cannot use the enteric nutrition just yet? So if the patient is still quite unstable, we usually recommend after the first 7 days of illness, that's when we start TPN. And the reason why we start either TPN or PPN after that 1 week is there's a higher risk of an infection. Think of it as a patient is bacteremic, and there's that infection just streaming through, and you have this access that is available, whether it's a central line or a PICC line or a Broviac, and you have a higher risk of the seeding infection into it if you give feeding through the TPN. Also, we've found that studies have proven that prolonged PICU stays associated with TPN early use versus enteric uses. Next question comes in. So how should we really evaluate the angiogram requirements of these patients in the ICU? Most places, depends on how resources you have, will use the indirect calorimetry. An indirect calorimetry is usually a good device, which I'll explain later on, that can determine the resting energy expenditure of these patients. However, it's not always available and it's not always attainable. And that's when we depend on our dietitian and our predictive equations, and we just use an over and underfeeding estimates for these patients. So what are the recommended target nutrition? And you need to understand, we're dealing with pediatric patients. Pediatric patients are not always a one number fits them. A general targeting is 1.1.5 grams per kilogram per day, but that is not age-based. You have to determine age-based specific targeting of proteins for these patients. You have to understand if you overshoot with your protein in patients with septic shock, that can be very harmful. Think of it as an anabolic resistance. The patient is in shock. There's a state of high steroids. It's in a catabolic state rather than anabolic state early on. So it actually can harm the patient if you overdo it with your nutrition in these patients. Now, how should we advance the nutrition in these patients once they're stable? And there's no right answer for that. It's always variable based on what guidelines you're using, what is the physician preference, what is the provider institution protocols here. We can use that. We start usually trophic feeds. Let's say we started at 5 cc's an hour, and you want to advance the feeds of that patient. You can determine it, let's say you increase it by 5 increments every 4 to 6 hours until you reach your goal nutrition. I've seen other people say if the patient is able to tolerate it, we increase it by half goal nutrition and then reach the full goal nutrition after 6 hours, that while weaning the fluids. So it's really increments, but the big test is you increase it by small increments in these patients, and you have to always observe for feeding intolerance as you advance. So this is the indirect calorimetry, and it can be used in non-invasive and invasive way, but here I'm referring it to the invasive way, which is connected to the ET tube directly. The problem with this in neonatal period, it increases your dead space in the circuit, which is important for CO2 clearance in your ventilated patients. But this is the best way to have an accurate measurement of resting energy expenditures of your patients and modify it based on disease and underlying pathologies. So the next question is, the medical student is interested in asking the dietitian, why am I not feeding this patient post-pyloric? Why are we feeding it in the stomach? And the details tells you is gastric feeds are very well tolerated. You should feed the gut as how it was intended to be. There's no risk of aspiration, pneumonia, or increased intolerance known in literature by feeding gastric versus post-pyloric. However, if a patient has proved to you they have a high risk of aspiration, the patient is telling you that they have high evidence of gastric feeding intolerance, then you should advance the post-pyloric feed to avoid aspiration. Now, the question is, you always have to remember, do not bolus feed in post-pyloric feeds. It's not as stretchable as the stomach. You can give continuous feeds or bolus feeds in your stomach, but you cannot feed it in the duodenum the same way, or the duodenum, depends on how you're post-pylorically feeding these patients. Now, the same thing, the patient got very sick, right? We increases the pressors. Now, they're on dual pressor support. They're in 0.1 of mics per kilogram per minute of both norepinephrine and epinephrine. The feedings are paused, and the parents and nurse are now asking, when can I feed the patient again? It's always important. The bedside will ask you, when can we feed this patient again? And in the literature, it does not really tell you that there's a cutoff dose of pressors above which you need to stop. But we know risk versus benefit. If you're giving enteric nutrition to a patient, let's say in norepinephrine, there's a decrease in splanchnic perfusion, there's a decrease in gut perfusion, and there's a risk of ischemic gut complications and pneumatosis intestinalis. I have seen us feed patients on a monotherapy, a single agent of vasopressors, typically less than 0.08, and I've seen us usually use caution at 0.05 mics per kg per minute. But that, again, is based on the provider preference and really bedside understanding of the clinical complications of this. With no signs of feeding intolerance, you can still advance the feeds for these patients. Now, case 2 is ARDS patient. If they come in, a 7-year-old PICU, severe ARDS, they're already in high PEEP, they're proning the patient, and their hemodynamically is stable, and they're asking you, when can we enterically feed the patient? There is no contraindication of feeding the patient. Knowing that early enteric nutrition in patients with ARDS, severe ARDS who are intubation, decreases PICU mortality. We know it decreases short length of stay in the ICU, helps you with ventilator-free days, and actually has a more protective role in these patients. They defined early enteric nutrition at least 25% and higher in their calculated energy goal. But I have seen us only feed them 5 cc's an hour. As long as we're using the gut, there's always improvement. And we like to use it within the first 48 hours once the patient is hemodynamically stable with no other comorbidities. Now, the patient is becoming worsening ventilators asynchrony. Patient is having patient-induced lung injury. He's fighting the ventilator. They're not as comfortable as they should be. And the decision was made to paralyze that patient using Vacuronium. Now, the nurses and the bedside parents are asking you, can we feed them while they're paralyzed? And the question is yes. Solely withholding feeds on neuromuscular blockade is not indicated. You can feed patients while they're on Vacuronium drips, as long as they do not show you any signs of severe GI dysfunction or shock state, you can still feed them on a Vec drip. Now, the third case is going to be talking about burns. It's a 9-year-old having 45% total body surface area burns, came in a house fire. Patient is intubated already, receiving the fluid resuscitation as needed per the Parkland formula, admitted to the ICU, and we're adequately giving analgesia, we're adequately sedating the patient, we're giving them good infection control. Now, the question is, how can we feed them? And this, you have to understand, is aside from your Parkland fluid resuscitation, aside from your urine output monitoring that targets your fluid resuscitation. There's two sides of this guidelines. One of them tells you you can feed the patients within 4 to 24 hours of the burns, as long as you do early enteric nutrition, even if it's a slow dose, and you have to make sure you're meeting their caloric needs. There's recent studies back in 2021 and recently from there trying to see if you can resuscitate the patient quicker than those 4 hours. Can you early feed those patients? And the question is yes. As long as they're hemodynamically stable, you're already adequately resuscitating these patients, you can actually start with less than 4 hours. Don't have to the 4 hours to the 24 hours mark. And the basic guidelines is give them proteins because they will need it. Give them carbohydrates. Be keen on your fat and make sure you optimize your micronutrients. Lastly, in the last minute, I want to tell you this. These are papers I always keep on me while I'm rounding in the ICU to evaluate my patient nutrition and what they need, hand in hand with my clinical pharmacist and my clinical dietitian. These are the Aspen guidelines for neonatal and pediatric patients. They talk about their protein needs, their caloric needs, their dextrosities, their electrolytes and micronutrients. These one also have the rest of the expenditure calculations that you have to carry on with you. And these come from the Texas Children Handbook or the UT Southwestern Handbook. And they also give you equations how to adjust your resting energy expenditure based on the patient's stress factors and their clinical decision. And lastly, this is the Holly-Seeger method to calculate their fluid. And also you can use the 4-2-1 way. All of these are going to be saved in the save of the webinar. So you can always refer back to them or you can take a screenshot of them. But thank you so much. These are my references. And if you have any questions, we can answer them in the Q&A. Thank you so much.
Thank you, Dr. Ali. Very informative presentation, elegant. Thank you very much. Now we listen to Dr. Fatma Al-Haddad. Fatma Al-Haddad is a friend of mine. She's an expert in pediatric nutrition. She's working in the field since more than 20 years. She has a master's degree and PhD in clinical nutrition and most of her experience in pediatric. I love her presentation, especially when talk about pediatric critical care. So let us to hear to Fatma without further delay about case scenarios in pediatric critical care nutrition. The floor is yours, Fatma.
Thank you. Can you see my presentation?
Yeah, let's see. Go on.
All right, great. Thank you so much. And please feel free for the moderators to stop and ask me any questions or just, highlight anything that you would like to focus on for our audience. So today I will focus on prescribing enteral nutrition in pediatrics. And in particular, what I wanted to do is really to focus on case-based studies. And these cases were actually real-life scenarios that I adapted to sort of better suit the teaching methods and really for the ultimate goal of enhancing your learning experience. So I will get started now. Amira was actually referred to a pediatric nutrition clinic by her neurologist. because he had concerns regarding her weight loss and her persistent feeding difficulties. So Amira is 2 years old and she has mild cerebral palsy, and her mother had reported that feeding had become a major struggle the past, I think it was 4 or 5 months, and that she had frequent coughing while eating. She took a long time to finish her meals, and she often refused to feed altogether. So already, when you're looking at your cases or your patient's overview, it's really important from the beginning, from the history, you'll be able to pick up some sort of red flags that we flag in our head as dietitians. First of all, concerns of weight loss, feeding difficulties, even as evidenced by the mother, struggling to feed her, coughing. So again, another red flag that goes into my head. And of course, she's a case of CP. So all of these things together, you need to keep them in the back of your head when you're analyzing and moving forward with this case. So this is just a brief overview of her case. Like I said, she's a 2-year-old female. Her weight was 7.5 kg, which was actually below the 3rd centile. Her height was 83 centimeters. Now, her ideal body weight was 12 kgs, and when calculated her adjusted body weight, it was 10 kgs. Now, looking at her Z-scores, it showed that her weight for age was between the -3.5 to -4, so that is indicative of severe underweight, although her height for age appeared only to have some mild stunting, but her weight for height, again, was also indicative of severe wasting. So in general, some of the symptoms that we found was failure to thrive. She did have clinically some muscle wasting, difficulty swallowing, question mark about dysphagia, and she did present with frequent respiratory infections in the past 6 to 7 months. So we had diagnosed her with severe malnutrition, and that was particularly due to her feeding difficulties, secondary probably to her cerebral palsy. But again, we needed to work her up a little more to figure out what was going on. So in terms of our nutritional assessment, we were able to note down that she had severe protein energy malnutrition, also that she possibly had dysphagia, and that was as a result of the choking and difficulty swallowing, which made her oral feeding quite unsafe. And there was a history of insufficient caloric intake to meet her energy requirements. Sorry, but my slides just disappeared. Can you guys see them?
Yes, we do.
I can't see them. I don't know where they disappeared.
You can reopen the PowerPoint again if you want.
I got it. So unfortunately, Amira was actually admitted into the PICU, and she was admitted with severe aspiration pneumonia and acute respiratory distress, which actually required her to be intubated. All right. So it's not moving forward.
Just close it and reopen it again.
All right. So what is her nutritional intervention? So given Amira's swallowing difficulties and malnutrition status, and of course she was admitted into the PICU, a nasogastric tube feeding was inserted, and the feeding plan was as per NGT initiated. So to be very honest with you, it was a short-term plan that we keep her on NGT feeding until she's stable and out of the PICU. And then her mother, as well as the dietitians that were following up with her, really had hoped that maybe later on she could transition to some sort of oral feeding if it was safe with modified textures. So in the PICU, what I typically use is the Schofield equation, although you could use the WHO equation as well. And just a note for those for the dietitians that are calculating using the Schofield, and in general, when you're in the PICU, use the child's actual weight. Even if they're underweight or overweight, it is recommended that you use the child's actual weight when they're in the PICU, okay? So when they're in the critical. So I did actually use the Schofield equation to calculate her energy requirements. After you calculate the energy requirements, it's important to add a stress factor. Now, because Amira did have growth failure and she was malnourished, the REE was multiply it by between 1.5 to 2. And actually, in my own calculations, I did multiply it by 2. In terms of her protein requirements, as per the Aspen requirements, for her age, she needed in between 1.5 to 2 grams per kg per day. And so using these calculations, we were able to come up with a nutrition prescription. Unfortunately, the institution that I work in does not have an indirect calorimeter, so we don't have the luxury of that. So this was a nutrition prescription for Amira. Her energy needs using the Schofield equation, and again, using 2.0 as her stress factor, was approximately 800 kcals per day. Her protein needs, according to, again, her actual body weight, was around 20 grams per day. And using the Haldey-Seeger formula, she required approximately 750 ml per day fluids for maintenance. So in terms of her enteral nutrition plan, I started with a basic 1 cal per ml pediatric formula, which was fortified with vitamins and minerals. And here, to be very honest with you, I liked what Dr. Adi said, that there is no one answer, and it's just quite variable depending on, the dietitian and the PICU team. But to me, I prefer to use the standardized 1 kcal formula, especially when we're initiating feed in the PICU. I do know some dietitians who will prefer a slightly higher kcal, such as a 1.5 kcal. I'm not quite sure, Christelle, what your opinion is on that, but this is how we started off with this particular patient. Do you have anything you'd like to?
No, actually, I think by practice, like you said, and we use usually the 1 calorie milliliter pediatric formula to have a better caloric need in the first phase.
Right, thank you. So we did use the standard formula, and it was a continuous feed via NGT. And again, the PICU that I work in, they have a standardized protocol, and it really depends on the protocol of your institution or the hospital that you're working in. So our institution, we started with 5 ml per hour, and it was increased Q6 hours by 5 ml if tolerated. And thankfully, we were able to reach, this patient reached 30 ml per hour, so about 720 kcals, which is 90% of her requirement after 72 hours. We were able to reach that. She didn't have any issues in terms of tolerance, no abdominal distension. She was doing quite well with this feeding plan initially. So we continued monitoring daily, monitoring her electrolytes, her labs, weight gain, and of course, tolerance to the feed. So Amira was extubated on day 4, and thankfully, she was actually shifted to a general pediatric ward on day 5 of admission. Now, when she was in the ward, we actually had a referral by the speech and language therapist. So again, I just wanted to focus on the part of nutrition being a holistic management of nutrition. So the speech and language therapist was involved to help us identify, both the physician and the dietitians, the swallowing assessment of this patient post after her stay in the PICU. And of course, because she did have, if you recall from the beginning, her history, issues with feeding and swallowing difficulties. So the speech and language therapist did a wonderful job. She was able to do a swallowing assessment and observe her oral motor function, tongue, lip closure, chewing ability. And she was actually able to identify delayed swallowing initiation and hence the risk of aspiration, especially using thin liquids. And so it was recommended that we modify her texture diet to something pureed foods and even. Now, the speech and language therapist was able to also do a safe swallow test in which we brought different types of textures of food, and we found that she required a level 4 of pureed foods and a level 2 for mildly thickened fluids, as per the International Dysphagia Diet Standardization Initiative framework. Now, I'm not quite sure if that's something that you do have in your institution. It's something that's being started in our institution, but when I was training back in Montreal, we were using this, and the dietitian and the speech and language therapist worked hand in hand in order to really determine at what level swallowing patients had. So coughing was observed with the thin liquid, so that was definitely contraindication. So the decision was made to feed, oral feeding can be initiated under supervision while she was in the hospital, and then a gradual reduction of NGT if that was possible. That was in our plan. So again, we took this opportunity to teach the parents about thickening the liquids. I'm not quite sure what you have in your institution. We just particularly had this one at that time. And we don't have it anymore, but we just explained how to thicken the foods using this thickener. And again, I just put the ID-DSI framework for those of you who are not familiar with it. It would be good to look at it and look into it as well in your institutions. Dr. Ali, I don't know if he's with us, but do you use this in the US or?
Yes, we do use it. It depends on different institutions that I've worked in, but we end up using this one as well.
Okay, great. All right, so in the ward now, the patient's out of the PICU. She's into the ward. The ward dietitian there will do a reassessment of her nutritional requirements. Now, here is the time where we can use maybe catch-up growth and use her adjusted body weight. So the nutrition prescription or calculation was at around 1,000 to 1,200 kcals per day. In terms of protein, it was between 20 to 25 grams per day, and fluids was approximately 1,000 ml per day. And we did use, or the dietitian did use her adjusted body weight for this assessment. So we did start the oral feeding trial. We had recommended that she has her 3 main meals and then at least 1 to 2 snacks. And we did encourage the oral feeding up as per the texture that the speech and language therapist had recommended. We did use a high energy oral nutrition supplement through the NGT at that time. And this is when this is when the dietitian prescribed a 1.5 kcal per ml nutritional supplement. And we had sort of agreed as a team that, including the physician, that if we were able to achieve 75% of our oral intake was achieved, then if less than 75% of our oral intake was achieved, then we would still need to supplement with partial NGT feeding at this time. And that we could possibly discharge her on a high calorie nutritional supplement via the NGT feeding if that was necessary. So after the 2-month follow-up, we found some really good weight gain. She gained 1.5 kgs. She reached 9 kgs after 2 months. We were able to remove her NGT. She was on thickened liquids and pureed foods. And she was taking a nutritional supplement, which the mom was thickening up and making it sort of like a pudding-like consistency and giving it to her. Definitely there was improved energy level. She was much more alert. She was responsive. And the mother reported that there was a decrease in respiratory infection, and that could very well be due to the fact that, you know, we had introduced a much safer method of feeding. And she did have a lot of follow-ups with the speech and language therapist after that. So some of the key lessons to learn, I guess, is that early intervention, nutritional intervention is crucial in pediatric malnutrition cases. And you know how they say it takes a village to raise a child? Well, it takes a multidisciplinary team to bring the best nutrition to these pediatric cases. And it's doctors, it's speech and language therapists, it's dietitians, it's the respiratory therapists, it's the nurse. All of these people, when they collaborate together, you know, they can really make major changes into the patient's outcome. And again, enteral feeding is and can be life-saving when oral feeding is unsafe. And again, it's important to involve key people when making decisions about nutrition and moving forward with that. So final thought, children with feeding difficulties require personalized nutritional care to thrive. So it's not a one size that fits all. And I'm always an advocate of early intervention, specializing feed techniques, and having a holistic approach to caring for that patient. So before we move on to my next case, Christelle or Dr. Ali, do you have any comments, anything you'd like to focus on regarding this particular case or that I brought to your attention?
From my standpoint, I think you did a tremendous job of how you present it, not just in the ICU, but how it trickles afterwards, which is something as an intensivist we kind of lack because we focus on how sick they are right now. And at times I've seen we do not prioritize nutrition as we should be. And we think is going to, after we stabilize the patient, is going to taken care of later on. And I like how you focus on early intervention with nutrition in these patients, optimize the outcomes of the patient at the end, and how you personalize the plan. So I think it's a well-rounded presentation of that case.
Thank you. I wanted sort of, you know, what I really wanted to do with these case scenarios is for the dietitians and the nutritionists out there, and even for the physicians, is it's a journey, right? It's a patient journey. And when you're looking at things in a holistic point of view, you shouldn't just look at it as, okay, I have to take care of the patient when he's in the PICU, or it's the general dietitian in the ward that will take care of it post. But it's the patient's journey. And his journey sometimes doesn't end when they leave the hospital because they do come back. So I just wanted to challenge you all to really think about it from that perspective, from the perspective of the patient's journey with the dietitian, the patient's journey with the physicians, and to really challenge yourself to look a little bit further than just sort of what you're asked to do most of the time. Christelle, do you have any comments, or are we good to move on?
I think I just want to highlight, Fatima, thank you so much, because you took us really on a nice journey and we saw how difficult it is sometimes. And I would like just to comment on the importance of having a speech language therapist with us. And you showed the ITSE framework, and many units do not adapt it. It's not a problem, but at least to have a standardized framework for all patients on the level of swallowing difficulties they have. So I think this is important. And second, just like it highlights the importance of how much sometimes as dietitians, as medical doctors, we need to also be very careful with the parents, okay, like because they are the caregiver, they are very worried. So I always emphasize the idea of communicating everything we change in our therapy, the next step always with the parents and the caregivers, so they feel involved because they will be taking care of their child outside the hospital afterward.
Absolutely.
So thank you so much, Fatima. Looking forward for the second case.
You're gonna
Yeah,
have
great. Yeah,
questions?
great. A lot of questions from the audience, but let
Yes,
us to
we have a lot.
at the end. Handle at the end, so we can
Okay.
think go for second case directly.
Yes,
Yeah.
okay, perfect. Yeah, go ahead. Thank you, Fatima.
Thank you. Christelle, please feel free to interrupt because this case is a PKU case. So please jump in whenever you need to. All right.
Okay, yeah, sure, I will do.
So just put this down. This is case number 2. So this is a 6-year-old patient with female again with PKU. And we were called to see her because she was actually admitted over the weekend, and she required enteral feeding. So we were called in from the team. Referral was made. So she's a 6-year-old female, known case to be phenylketonuria. She weighed 18 kg and was 110 centimeters in height. She was admitted actually to the PICU with pneumonia and poor oral intake of about 3 or 4 days, if I can recall correctly. And she'd actually been NPO for about 48 hours. And I believe it was possibly because they couldn't find her a bed in the PICU. And she just wasn't stable enough to start feeding. And so it was during the weekend. And so we were referred on Sunday to her to review and start enteral feeding. And just a brief overview of this patient. She's 6 years old, 18 kgs. Her BMI was 14.9, so it was within the normal range. And she, like I said, background 48 hours, hadn't had anything. And she's a known case of PK. All right, again, like I said, always when you're taking the history, just think of things that are red flags in your head. When I look at this case, her growth was not too bad. Her BMI was in the normal. She's a known case. She's 6 years old. But again, what goes in my mind is that she's been 2 hours. She hadn't had anything to eat, and that's what we do know. And just poor oral intake prior to that as well. So in terms of nutritional assessment and goals, our overarching goal was to maintain metabolic stability and to prevent catabolism, and to meet her energy and protein requirements while restricting her phenylalanine levels. So from her anthropometric measurements, we found that she was just mildly underweight. She just had some mild stunting, and her growth velocity was actually slightly below the expected for her age. In terms of biochemical data, her plasma phenylalanine levels were at 420 micromoles per liter, which was slightly above the target, which we prefer. With normal target range was between 120 to 360. Her albumin was actually normal, and so were her electrolytes, but she did have a slightly elevated CRP, and that's probably secondary to her infection. She was admitted with pneumonia after all. In terms of her clinical background, she had an increased energy need as she was admitted into PICU, but at the same time, we have to sort of balance the fact that she is a PKU and we have to avoid excess phenylalanine intake. So in our hospital, we have our own clinical guidelines and clinical pathways that we have adapted. And this is what we do use in our institution. So because she was 6 years old, we use these recommended daily nutrient intakes to establish nutrition prescription. Now, Crystal, I don't know how things are in your institution. I don't know if you use a certain standards or you have your own standards that you reference off, but we've established pretty much for all the metabolic disorders clinical guidelines to use in our institution.
Actually, we use international. We don't have our own specific guidelines due to the we don't receive as much cases as it's not our bulk of cases. That's why.
Okay. All right. So using those standards, we initiated her prescription. So in terms of energy, we gave her between 1,620 to 1,800. That was her requirements. In terms of protein, she needed about 36 minimum grams of protein. And remember that we need to provide the majority of this as phenylalanine-free amino acid. And I'll talk to you about why in the next couple of slides. In terms of individual tolerance, maximum we'd go at 200 to 250 milligrams, but not the first day when she was in the PICU. And again, we'll talk about that in the next slide. In terms of fluid requirements, it was 1,500 ml per day. That was her maintenance. And again, if you go back, it's within the prescription that you see over here. Oops, for her age, it matches or it meets the RNI requirements. So She was a PKU since infancy. She was on a formula, and she normally takes a phenylalanine-free medical formula with measured natural protein allowance. And because she has been very sick the past 5-6 days, and it was admitted in the PICU, the enteral route was indicated at this time. So these are the formulas that we typically use for PKU, or what's available in our hospital. So we actually had to withhold the natural protein for the first 24 hours because that goes with our protocol that we use. So because her phenylalanine levels were at 420, slightly elevated, we withheld the natural protein for 24 hours. And we just monitor again to see how her levels are. So Christelle, I don't know, do you guys do that as well? Do you withhold when they're phenylalanine, especially in the PICU, until it stabilizes and normalizes?
Yeah, we give 0 phenylalanine, actually. Yeah.
Exactly.
And we
So
use totally phenylalanine-free formula as their energy needs.
yes, absolutely. So that's exactly what we did for the first 24 hours. A completely phenylalanine-free formula, which she normally uses, but without the natural protein supplements that we give her, right? So she was started on continuous feed. Her goal rate was between 60 to 65 ml per hour while she was in the PICU. So her medical formula, which was the phenylalanine formula, provided the majority of her protein, which was about 35 to 40 grams per day. And like I said, we kept her on phenyl-free amino acid mixture for, it was a little more than 24 hours, to be honest with you. I think it was more close to 30-something hours. And we were able to reach 60 ml of continuous feed. And we didn't have any issues again with this patient in terms of tolerance. She was doing fine and tolerating the feed. So when to start natural protein. So after the 24 hours, when we did repeat her phenylalanine levels and they were back to safe levels, then that's when you can consider using adding a little bit of natural protein. I do want to mention that with very small infants, they develop deficiencies. They can develop deficiencies quite fast. I don't know, Christelle, have you noticed that in the infants, the young ones, when we do avoid protein for a long time?
Yeah, and there are some studies mentioning it, of course, but I think it's based on a case by case too, and how long did they stay without the protein.
Yes, yes. So please, be careful when you are both initiating protein when the phenylalanine was high, and then even reviewing the quantity of natural protein, making sure that you provide the safe level of phenylalanine, and always start on the lowest dose and then gradually increase. So this was her feeding prescription when we reviewed it. After initiating natural protein, it was 1,700 kcals, 40 grams of protein, 200 milligrams of phenylalanine. The PKU medical formula provided most of the calories and the protein, and she had a very minimal amount as per the recommended natural protein. And we did have to add some modular formulas to reach her energy requirement at that time. So monitoring is very important with these cases. So daily phenylalanine levels, if you have that as a luxury, is great until it stabilizes. Of course, weight and fluid balance is very important. Looking at her nitrogen balance, so make sure urea, ammonia, if available, always to repeat that and check that. And definitely clinical tolerance. So GI symptoms, feeding intolerance or tolerance, look also at her glucose levels. That should also be monitored as well. Now, this patient was transitioned from the PICU to the general ward, and it was actually after 5 days in the PICU. And she was extubated Thankfully, alhamdulillah, on womb air, her inflammatory markers showed improvement. Her oral intake was still limited, but she was tolerating the NG tube feeding fine, and she was shifted to the pediatric ward for further nutritional rehabilitation and monitoring. So that's when our ward dietitian takes over. In terms of nutritional goals, continue metabolic control. So we want to make sure that her phenylalanine levels are within the normal range. And at this time, to try and work with the parents, the mom, to really support recovery and catch-up growth. And definitely begin the transition from continuous NGT feed to bolus feed, and then hopefully partial oral intake. As much as possible, personally, I like, bolus feedings is a lot more physiological, especially in the wards. And always I have in the back of my mind, if we can get the child to feed normally and safely, then let's do that. It's never just a no. Let's try it using a holistic, multidisciplinary team approach. And again, we use those time to maintain family education on diet management. So feeding transition strategy. So day 1 to day 2 in ward, we started bolus feedings during the daytime. And again, she was tolerating that beautifully. We had no problems. Day 3 to 4, we encouraged small oral intakes of phenylalanine restricted foods. And this was under the dietitian's guidance. And thankfully, we were actually able to discharge her at home with a combination of oral and NGT feeds, again, with the goal for full oral feeding at home, because, like I said, she was feeding completely 100% orally prior to her health issues that required her PICU admission. Right. So again, in the wards, we need to monitor phenylalanine every 2 to 3 days. Weekly weight diet record is important, especially from the caregivers. Monitor tolerance, vomiting, diarrhea, again, constipation, and then educating parents on natural proteins, how to measure that, and preparing the formula afterwards. So just some key take-home messages about this patient. So PKU patients in critical care, they need early and tailored nutrition support to prevent catabolism. And of course, neurotoxicity from the high phenylalanine. Energy must be adequate. We need to make sure we're giving enough calories to spare protein and muscle breakdown, which releases endogenous phenylalanine, and we need to make sure that her protein requirements, and particularly in that period, are met primarily through the phenylalanine-free medical formula with only a very controlled amount of natural protein and only when indicated. It is a multidisciplinary team. You need to have your physician, your dietitian, your nurses, if you need your speech and language therapist as well, so that you have a safe transition between the PICU, the ward, and home. And of course, regular phenylalanine monitoring is non-negotiable. It really does help the dietitian guide us to adjust protein and feeds. So thank you so much. That's the end of my 2 cases. Christelle, do you have any comments or questions or anything you'd like to highlight? I think you're muted.
No, I think it's very interesting, and really it shows that, because when we work in ICU, specifically in countries where PKU may be one of the most prevalent inborn errors of metabolism, we have to expect that they will come to the ICU, and their first few days is very critical. So, and their nutrition is much different than the other children we see. So thank you for highlighting this.
Absolutely challenging, yes. Dr. Ali, do you have any comments?
No, I think the most critical thing in these kids, but again, I work in a high resource settings where our genetic and metabolic programs usually have a sick regimen for these kids that they walk in, even from the emergency room, we start their resuscitation early on. I think this lecture highlights these things, even if you do not have the early intervention from your genetic or metabolic disease, how you can think through it in your PICU until you get those referrals working up. So I applaud you for it.
Thank you so much. We
Thank
do
you,
actually-
Fatma, really, for a very much amazing lecture as well. I get benefits despite I'm an adult physician, but really it is clear and to the point, and use really a personalized care, which is, I like it very much. Now we'll leave the floor to Crystal. Crystal is very well known. She's an assistant professor at the American University of Beirut, and really welcome Crystal here to our webinar. You will lead now, and then you look at the question and answer from the audience in the next 15 minutes, please.
Okay. So first, I'm very happy to be there. Thank you so much. And to be with you as a moderator with such an esteemed panelist, and also to see so much engagement from the audience and their Q&A. So I'm gonna ask them specifically. I think we have two questions for Dr. Ali. The first one, I think, was about the NG tube feeding that you mentioned in your in your lecture, and they are just asking if you give them as bolus or continuous feeding in NG tube. What is the most preferable one? Over
That's a
to
great
you, Dr. Ali.
Yeah, that's a great question. I think if you think logically of it, bolus feeding is the most natural way of feeding, but it depends on how long have they been NPO. If that's a kid that I expect her recovery within 48 hours and they have not been sick for that long, I would bolus feed. But we've seen this more with the critically ill children who are having pressor needs, or septic shock or ARDS, that we do continuous feeds until we prove tolerance and then transition to bolus feeds from there.
Okay, so it will depends mainly on their phase of critical illness accordingly. Another question was the that mentioned, how can we tolerate assessing tolerance of feed, specifically because you mentioned how you use indirect calorimeter, but in certain settings, hospitals, indirect calorimeter may not be of availability and may not be mentioned of availability. So how can you assess tolerance of feed if not indirect calorimeter? And there is another question about residual volume. I will say it because maybe you may say by measuring residual volume. So if you are measuring residual volume in neonate, how much of the residual volume would be concerning, and there are some practices, we see it a lot maybe in adults more than peds, to give back, but also in peds to administer back the residual volume to the patients. So what is your point on this?
Great questions. I'll defer them to two parts. So the tolerance is, we go clinical. Indirect calorimetry will give you the resting energy expenditure, but it's not going to really tell me the tolerance of the patient to the feed that you're giving. So I go for clinical signs of abdominal distension, if the patient having worsening abdominal competition, KUB findings of gaseous distension. Is the patient stooling or not stooling? Overall clinical outcomes. After I fed the patient started to become worsening hemodynamic instability. These are signs for me to evaluate intolerance. Now, for tolerance part is once I get the patient back to the deresuscitation phase, where I already diurese the patient to the dry weight where they are when they got admitted, I evaluate their nutrition based on the weight gain they stay on the ICU based on their length. And this is the gold standard that I like to go with than anything else. And then I defer to my dietitians to how they make the equations of are they meeting their caloric needs per day or not. Residual feeds is, I would defer to you guys, but it's more of a NICU practice than a PICU practice, at least in the institutions that I worked with. We do not usually give back the residual feeds for the patients unless they're chronically sick kids are having a habit of gastric residual. So we usually see 30 mLs per kg per day is usually outcomes that you expect physiologically in any patients. Anything above that, you replace it, depends on fluid boluses or residual or re-entry. At least that's in our practice that we.
And I don't think, Fatima, do you want to comment on the practice of the residual volume?
Hi, Christelle. They've stopped doing that now. That's from my understanding. Before they were doing that very frequently, and unfortunately, what happens when they do continuously check is that they're not getting the feed, right? And that's impacting their caloric intake. Dr. Ali, I'm sure you hear dietitians complaining about that. having to recheck. It's only when there's an intolerance will they check their residual, to be honest with you. Like Dr. Ali said, abdominal distension, vomiting, not tolerating, it's impacting their labs, etc.
Yeah, but if you are using numbers, are you actually, which is the magic number? And in adult, we have 500 in that range. Do you have any number, specific number?
No, in pediatrics, we don't. The only thing we know is usually pediatrics have a normal physiological loss of 30 mLs per kilogram per day, whether it's down or up, but we do not do the practice of refeeding residuals in the PICU. Again, NICU are still doing it, but PICU we don't.
Okay.
Yeah, exactly. And sometimes it may be like, if we want to talk numbers, some guidelines, practice guidelines mention like 1/3 of that they are eating. This is like, you cannot give a specific milliliter, you give a percentage of what they are receiving. Like 1/3 usually is a common but it's not like it's not like it's not great. It's not a graded recommendation. It's just a practice standard. And I would mention that on residual volume, like in our institution, sometimes we do it only for the first 2 days, just to make sure everything is going well, and then we stop doing it for the rest of the stay in their hospital. I don't know for the one who asked this question, if you feel like you have an extra follow-up question, please go ahead and chat and type it in the Q&A, and we will be happy to answer it. Another question is, I think it's of course it's for both of you, Dr. Ali and Dr. Fatima, but Fatima, it was based on your first case, and you think what is the best formula to be used? You mentioned the 1 calorie per cc, but they are saying that usually normal formulas are very heavy in carbohydrate. Do you have any opinion on hydrolyzed formula?
Good question. So we don't have the luxury to start with a hydrolyzed formula to begin with these patients. We do have certain criterias for the hydrolyzed formulas that we do use. So I typically like to use a complete 1 calorie per ml formula. You do have to keep in mind that hydrolyzed and sometimes even amino acid based formulas, they transit the gut very fast. So keep that in mind as well. Absorption wise, you may have better tolerance, but again, I definitely prefer the whole protein, intact protein, if they're tolerating it. If they're not tolerating it, then that's fine. I do, though, know some dietitians in their PICUs that they will go straight away. Their first line of feeding would be a partially hydrolyzed formula, 1 calorie.
Yeah, Dr. Ali, would you like to add anything on Fatima's response?
No, I think she answered that question adequately.
Yeah, I would just add that always we have to go for non-hydrolyzed formula, a normal formula, because it helps more the adaptation later on of the baby also, because we don't want him to get used on hydrolyzed formula. So a second, I'm gonna skip one question and get back to it just to keep the flow of ideas in it. And the question is about a protein requirement for patients is 1 to 1.5 in PQ was mentioned in your presentation, but what about patients with renal diseases? If you have infants or children with renal diseases. So go ahead, over to you, Dr. Fatima.
Good question. No, we do have to adapt to it depends on what stage they are. Are they end stage? Are they on dialysis? Are they on peritoneal dialysis? It really depends on their which stage they are in their kidney failure. So we would modify that, absolutely.
Okay, and I'm sure there are some protein requirements specific for renal patients that take priority over other requirements.
And it depends on again, like I said, what type of, if they're on dialysis, if they're end-stage renal disease, if they're on peritoneal, so it really does depend, and there are a set of guidelines specifically for those patients.
Okay, and exactly. And what about there is a question about cerebral palsy developmental delay patients, although there are two different types of some patients have development delay, but they are not cerebral palsy. If they have specific growth charts for them that you use, or do you use the normal growth chart?
Normal growth charts.
Yeah, there are some growth charts specific for specific disabilities,
Yeah,
for
send you.
prematurity and so on that we can use. But cerebral palsy specifically, usually we can go for normal growth chart, like Dr. Fatima said. I think another question is why the recommendation of not starting TPN except after day 7 of PICU admission?
So it comes from the Aspen guidelines. There are current trials that are happening predominantly in Canada and Europe that are trying to test it further in the first 7 days. But the Aspen guidelines and the SCCM shows if we start TPN in these patients and they're still in the bacteremic phase of the septic shock and their vasoplegia, you're increasing the risk of your line infection, you're increasing risk of these patients for developing more associated shock state. They also prolong their ICU stay in the hospital, and they also worsens their ventilator-free days. So that's why we do not recommend using it early. And since we can use the gut, since we can enterically feed, it always takes priority over TPN in these patients anyway.
Dr. Ali, may I ask, but if an infant or a child was admitted with a known necrotizing enterocolitis or anything, of course, then TPN will be prioritized, right?
Usually after the first 48 hours, what we need to find is we need to find a good stable vasopressor requirement in these patients and know where we resuscitated that patient pretty well, because these patients are usually dependent on their Broviac or their long axis. And the worst thing you can do for them is start the TPN early and lose that permanent line because they usually have Bas vasculature. So usually wait 48 hours before they start the nutrition and just supplement it with balanced electrolytes or TPN-like fluids in their IV access.
Okay, thank you. Next question is, for post-discharge for patients, how often should they follow up with the dietitian? I think it's a tricky question because it would depend on any. I can jump in just to say that we rarely have policies or recommendation or even internal institutional policy that mention this. But I will leave it to you, over to you, Dr. Fatima.
Absolutely. We don't have anything unified when it comes to how often we need to follow up with the patients. So unfortunately, our follow-up appointments can be very, very long. So we will actually book in the patient as an extra or a follow-up within 3 weeks to 1 month to make sure, or even do a teleconsultation where we'll check up and make sure everything is okay. Typically, we will see them maybe every 4 to 6 months if things are stable.
Thank you. But of course, if you can catch the patient before, if you can make him see you before, then it's much better. But it's not that as easy as Dr. Fatima said. Okay. I have a question. I'm trying to reformulate it a bit. But if you have a patient with respiratory problems, sometimes we increase the feeding. So is it better to keep it low rate feeding? I'm trying to understand the question. Is it because, for example, if he's still intubated or a child, so better low rate or increase the feeding up to requirements? Any comments from Dr. Ali or Dr. Fatima on this?
We can rephrase the question as in if a patient comes in ARDS, is it okay to advance the feeds to goal rate? And the question is, as early as you can to start enteric feeds, as the patient tolerates it, yes. And if the patient proves that he can tolerate these, you can go in small increments until you reach your goal nutrition. Goal nutrition in ARDS will help patient recovery faster as long as they're not at risk of aspiration. And you can either pyloric feed or post-pyloric feed. But I hope this answers that question if I understood it correctly.
Yeah. And please go for the one who asked this question. If there is anything we missed, please ask it again, and we will be happy to retarget it. And I have a question: what formula are you using for the adjusted body weight when doing your calculation, Dr. Fatima?
what formula I'm using? You
Yeah.
mean calculation?
To calculate adjusted body weight.
There's a general formula for adjusted body weight. You can easily find that in the nutritional manual.
Okay.
And or I can share it with you. That's fine.
Okay. Can you do you mind, Dr. Fatima, to put it on the chat, and I will answer it directly to the person asking this question.
Sure.
Okay.
I posted mine and the answered questions, at
Yeah,
least the
I
one
saw.
I used, but Dr. Fatima usually have a lot more in her arsenal than I do with these questions.
Yeah. I will also take the one that
Okay.
Dr. Ali.
It's very well, Crystal.
Yeah.
The formula for adjusted body weight for adult pediatric is the same. Like you use the ideal body weight plus 0.25 times the actual minus 9.
This is the one I'm putting on the chat for everyone, but just in case Dr. Fatima would like to share something. So can we give a thicker formula? I'm assuming consistency via tube feeding. Do you mean like I'm assuming these are the formulas we use usually for anti-reflux or something like that? Orally, can we put them in the tube feeding?
It depends on the size of the tube that the baby is inserted in the NGT tube. So of course, if it's a tiny baby, even AR formulas sometimes will not go through, to be honest with you. So again, it really depends on the size of the tube.
Mm-hmm. And usually tubes given for infants are very are a very small diameter, so make sure to have a good viscosity out of it, and do a good flushing. Usually is always the
Yeah.
best thing, not to make sure. I will just go back to there is a question on the adjusted body weight again, and they are just not asking of the formula, but do you use it for drugs, fluid, or just for feeding? I think Dr. Ali also can jump into this answer.
Depends. So I usually use the dry weight that the patient came in that had the chronic medications. If this is a patient who's in the ICU who just came in fresh and was previously healthy, I just use their previous recorded weight. I do not usually adjust for their body weight unless they're chronic patients that have been here for a very long time, or patients with specific syndromes like Prader-Willi syndrome, or a patient with severe BPD, then I can usually adjust for it, but not routinely. I think it makes a lot of errors in the pharmaceutical difference than the feeding. So I defer to your own protocols, but that's not the practice that I think.
Exactly.
Completely agree with him. I'd use it just for the feeds. I wouldn't use it for the medication.
And what do we use? What can use in patients whose highs we cannot measure due to critical illness?
It's very simple to measure the height, even if they're in the ICU and ill, even with a measuring tape. I've never had that issue with pediatrics. I don't know, Dr. Ali, do you have any issues with ever measuring height in the PICU?
No, I think the two cases that are maybe challenging for nurses are severe CP patients with severe contractures or severe abrochirosis where they have that severe contractures. But there are ways our nurses and nutrition add the height based on how they do it. So you don't have to actually spread the patient fully. You can use their contraction and go with it to measure that weight. I hope that is what they're.
Yeah, and it's sometimes even if the child is longer than the recumbent length we usually use, the board, they can take a tape
Yeah.
and remove it from it as a general rule, 0.7 centimeter, and it can be converted to height. So because usually the height measured while sleeping and the length is a bit higher than the height. So I think it can be easy done.
Yeah. I've never had an issue with that, to be honest.
Yeah.
Kristen,
Okay.
maybe last question, please, for the time.
Okay, last question. Okay. So I have okay, I think this is an important question because how long should we wait for the NG tube in pediatrics before we opt for PEG tubes?
It's recommended if the patient is will not be able to eat orally for more than 4 to 6 weeks to do PEG tube. But to be very frank with you, that's not what happens here in our institution. A lot of the parents refuse PEG tube insertions, and I've seen, unfortunately, children years on NGT, although they're indicated for a PEG tube. So the reality is quite different from the theory that we study in university.
Yeah, exactly. And some patients, if we know that they're gonna use it for very long time, sometimes we can offer the PEG from the first week, like, because we're gonna know that he's gonna be for certain, maybe cerebral palsy or so on, they may need their PEG for longer time. I will just add one question, because it's just important also, the water that you use to flush the NG tube should be added to the total fluid needs. And I will jump to say yes, please do, because any extra fluid can be also detrimental to the child. Dr. Fatima and Dr. Ali, if you would like to add on it or add any final note also.
Absolutely. I mean, that's some of the ways that we can actually reach their fluid requirements is through the flushing. So whether it's 30 ml or for the older children, 40, 50 ml, definitely include it in the total fluid.
Okay. So I thank you for your engaging question. I hope we answer. I try to pick the one that are mentioned, and they may be a bit controversial. And there is one question I'm just worried. I just need to ask it, because why do we give caffeine to some pediatric patient in the NICU?
So it's all right. So you have to
It's
understand we're giving
important to
caffeine.
just target it. Yes, yes.
This is not nutritional. The caffeine we're giving is for apnea of prematurity. There are
Exactly.
studies that shows in premature infant, if we give caffeine, it helps with apnea of prematurity. The same studies at times show in bronchiolitis patient with RSV specifically, if they're in the first month of life, it might be beneficial. But the predominant approved usage is only apnea of prematurity, no nutrition needs. The kids do not need coffee.
It's just I'm answering just not to have any misconception about it. So thank you so much. I will give it over to Dr. Khalid for final conclusion. Thank you. There are a lot of engaging questions and a lot of audience who stayed not only stayed till the end, they are staying with still typing some question till now. Thank you so much.
Yeah, thank you, Crystal, very much. Thank you very much for moderating the session. Thanks to everyone. Thanks, Fatma. Thanks, Dr. Ali. And thanks, Crystal, Dr. Amr. And thanks for the audience. And see you again for the next webinar. We have webinar monthly from our fellowship, and also the same for pediatric fellowship. So stay with us and see you. Bye-bye.